I wanted to thank all the speakers. I learned a huge deal of information during this course, and I hope you did too. I think in the end that there's nothing we cannot see with ultrasound. It's such a precise tool that allows us to see so many things that that we typically don't, we cannot even see with any other imaging techniques. And I hope with this talk, if you're still awake, that you can actually appreciate and think what ultrasound can show us in the first trimester of pregnancy. So I will advance my slides. Again, I have nothing to disclose, and we will, at the conclusion of the presentation, we will assess early pregnancy by transvaginal ultrasound. We will evaluate and measure the early pregnancy landmarks. We will hopefully diagnose placentation in the first trimester and distinguish normal from abnormal pregnancy, and how to perform a good patient follow-up with that. So in the normal first trimester, I don't know if you know this, but in the United States there was a task force a couple of years ago of which I was part, and it was to introduce a unified lexicon for the first trimester of pregnancy, and so we actually met every 2 weeks for about 6 months in order to issue this publication in the end. And so these are the structures and the landmarks that we evaluate by ultrasound in the first trimester. Of course, it's the gestational sac and then the embryo. We don't call it any longer a fetal pole. The yolk sac stayed the same. Cardiac activity instead of heart rate. We don't use that lexicon anymore. And then the placental location. So the gestational sac, we start with the first one. It's present as early as 4 weeks of gestation. It's constituted of an echoic ring, which is the trophectoderm, surrounded by surrounding an anechoic center, which is the fluid, and it's embedded only in one side of the endometrium, so it's eccentric. It's also called the double ring sign and intradecidual sign, whichever way you want to call it. Those are accepted nomenclatures. And it's measured by the average of 3 diameters when we use the Hellman methodology, or only 1 diameter, which is and I'm sorry, this is going on its own, the Rempen diameter. And we know that a small gestational sac is suspicious for failing pregnancy. We will see a little more about it in the next couple of slides. So this is a normal gestational sac at 6 weeks and 3 days, and as you can see, the average diameter is just about 11 millimeters in this case. But a small gestational sac can measure just about 10 millimeters, and it's still considered a small gestational sac. The embryo. So the embryo is the second structure that we typically see. This is an electronic microscopy of an embryonic life at 3 weeks, in which corresponds to 5 weeks gestation. As you know, we include those 2 weeks from the last menstrual period in our assessment. And so you can see how ultrasound gives you exactly the same picture as the electronic microscopy. So it shows you the embryo on top of the secondary yolk sac within the gestational sac. And so, again, it's just to show you how the ultrasound is reliable. Here is an embryo at 6 weeks and 3 days. That's the same embryo that we showed the gestational sac before, and it measures 5.8 millimeters in diameter. However, as the pregnancy progresses, we know that the embryo will become from a disc to a rod to a C-shaped embryo, and that happens at about 7 weeks gestation. That marks the beginning of the ultrasound imaging of the amnion. So we cannot see the amnion before 7 weeks. It's only after it becomes a C-shaped that we can actually see the amnion. So very important landmark, because we can actually detect these IUGRs, if you will, and if you allow me that term, even in the very early first trimester, and as long as we can identify that amnion. So it's until 53 days, the caudal portion of the embryo is actually a tail that is reabsorbed at about 8 to 9 weeks gestation, and then we cannot see it any longer. And you can see the tail right in this beautiful image that my sonographers prepared. It's right there. Oh, you cannot see it. I need my little magic pen. Which is right there. You can see the tail. And then it's only after 60 days, so at 10 weeks and 5 days, that the head becomes the most cephalad portion of the embryo. And then until 11 weeks, so we measure the longest fetal diameter rather than the real CRL or crown rump length. And we know that it grows just about 1 millimeter per day from 6 weeks until 9 and 4. And I'm sure you all know that the first trimester actually ends at 13 weeks and 6 days. So that's the marking between the first trimester and the second trimester. However, we call a fetus starting at 10 weeks gestation. So a little bit of confusion there, but that's what our predecessors decided for us. So in summary, the CRL, or the longest embryo diameter, is the most reliable method to estimate the gestational age. And the estimated date of delivery should be changed when the estimated gestational age is greater than 7 days from the gestational age, which is by LMP. So going on, it will all come together in a little bit, I promise you. The yolk sac. So it should always be visualized when the mean gestational sac diameter is more than 8 millimeters. However, we can see it even before. And a large yolk sac is associated with failing pregnancy, while a small yolk sac, or less than 2 millimeters at 8 to 10 weeks, is associated with adverse outcome of pregnancy. And I was so curious that we actually did a study on that, so I will show you in a second. The misshapen yolk sac, I don't know if you've ever seen it. I've seen it multiple times. At 6 weeks gestation, the sonographer runs to me saying, I can see a heart rate or a cardiac activity, but I see the yolk sac that is very misshapen. And so I typically just let them know, just let the patient drink, tell her that she's dehydrated, and then the next time we do an ultrasound, the yolk sac will be completely normal and perfectly round. And indeed, invariably, it always happens. So never be scared about a misshapen yolk sac, because it doesn't mean anything. And then the small yolk sac instead, as I said before, is associated with impending failure that will happen though after 10 weeks gestation typically, because what I found is that the small yolk sac is associated to a placental insufficiency. So just to notice these very small details whenever you do your ultrasounds, because you can actually tailor the patient's follow-up for the following few weeks. So in this case, I wanted to show you a normal yolk sac at, again, 6 weeks gestation, which should be more than 2 millimeters in diameter, and then a large yolk sac. In this case, this was a 4.5 millimeters. The cardiac activity was measured at 121 beats per minute. So the baby was considered completely normal on ultrasound if it weren't for this large yolk sac. And so we did this study. We measured the yolk sac in 239 early gestations, going from 6 weeks through 10 weeks gestation, and actually 5 weeks because we start very early. And we followed them longitudinally. Almost every week we were following these gestations. And all these dots that you see here actually represent all these measurements. And you will see that some of the dots are red and some are green. The red dots represent pregnancies that were lost. And instead the green dots represent the pregnancies that went to an end. So I was telling you about before the large yolk sac, and what it represents, at least for this study that we analyzed all these patients, it was basically a pathognomonic sign of genetic abnormalities. In this case, you can see this large yolk sac here at the embryoscope. Dr. Rouleau, we do that too. And this large yolk sac that initially I thought it was an air bubble that I had introduced with my hysteroscope. And instead, when I saw the stalk, I knew that this was indeed the large yolk sac. And in this case, this was a trisomy 22 for this patient, which was very common apparently among our patients. In this other case, you can see instead, again, a larger yolk sac, which was followed for longer, like at 6 weeks, the cardiac activity was still present, so we just warned the patient that this might not be such a great pregnancy after all for the outcome. And then we saw it at 8 weeks, and the yolk sac had increased even more. And then at our embryoscopy, we found exactly the same little crest that you could see at 6 weeks gestation. You could see it also at that time with the hysteroscopy, and so that was actually a 69XXY karyotype. So this was a partial mole that was identified as early as 6 weeks gestation when you couldn't even interpret what the results of these were. So just think in the back of your mind, every little thing we measure when we do our first trimester ultrasounds matters for that patient's outcome. So the double bleb sign, I don't know if you've ever seen it. I've seen it multiple times. And in the beginning, they used to say in the early 2000s, oh, this is a sign of trisomy 21. So trisomy 21 babies will have this double bleb sign, but they didn't know what it was, right? So now I can tell you what it was. So this larger bubble is actually the yolk sac. And the smaller one is the amniotic sac, and in the middle is something that we can barely see. It's the actual embryo. So this was an embryo that unfortunately had passed very early on at around 6 to 7 weeks gestation. It already had IUGR, right? And so it was not growing. And so you can see that the amniotic sac is there, but the embryo had not really changed its configuration from a rod to a C-shaped. And you can see this double bleb sign, which is nothing more than, again, the amnion and the yolk sac together. And the yolk sac, most of the times, is bigger than the amnion. So this was a very early loss. And indeed, it was a trisomy 21, because those are the ones that can give you this delayed IUGR, or I would say early IUGR. So is a summary, and I'm sorry, I'm going back and forth here, but the yolk sac diameter cannot be used to estimate the gestational age because it varies depending on what is the karyotype and then the placentation of that pregnancy. And however, it's a very important indicator of pregnancy loss. With a smaller or larger yolk sac, so the smaller can frequently associated with placental dysfunction, and a large yolk sac more frequently associated with genetic abnormalities. And for placental dysfunction, I mean mostly the antiphospholipid syndrome that can give us this kind of findings. So the cardiac activity, it's very important, right? It's a yes or no. If it's present, then the embryo is alive and possibly doing well. If it is absent, it's already a miscarriage instead. And so here you can see a normal heart rate at about 6 and 5 weeks gestation. And here is a very old paper that describes how the heart rate changes with gestational age. And it's something that we should keep in mind because, of course, if you have a very low cardiac activity at beats per minute at 5 weeks gestation, that could be completely normal, as opposed to when you see it at 6 weeks or later, that you should have an increase in that cardiac activity in the very early first trimester. And so here we can see again a normal cardiac activity with 115 beats per minute, and an abnormal one still at the same gestational age, 6 weeks and 3 days, with a much lower beats per minute of 95. The cardiac activity is not a reliable method to estimate the gestational age, again, because it varies with it and it varies with the health of that embryo, and so it's not a good method. However, the embryonal heart rate could be completely normal, even if less than 100 at 5 weeks gestation, but it should be more than 100 after 6 weeks. And otherwise, it could be an indicator of a failing pregnancy in more than 40% of the times. And this was Peter Dubilet from Harvard. He's a radiologist who has studied cardiac activity for a very long time. So we jump to placental location, and can that be diagnosed before 7 weeks gestation? So typically that's what we do, right? We notate on our reports the placental location only after 7 weeks, because that's when we can see it. However, can we do it before? So I've seen this beautiful picture that Dr. Palumbo showed yesterday, and I said, that I need that picture for my presentation, because what we know from doing IVF is that the embryo implants with the inner cell mass down towards the decidua, right? In the human. In the mouse, it implants actually on the opposite side, from the trophectoderm side. So, but what we know in the human is very important. So we know that where that inner cell mass implants, the trophectoderm that is right behind the inner cell mass will be where the placenta will form. Okay, and so knowing that, we can certainly tell where the embryo implants or where we see the yolk sac. If we cannot see the embryo yet, that's where the placenta should be. And so we performed this study in 57 pregnancies. Some of them were also twin pregnancies, and so we found that the placenta then corresponded to the position that we had predicted at 5 weeks at the 20-week scan when they do the fetal anatomy. And so it was very important to us, but you would say, but who cares where the placenta is, right, at 5 weeks gestation? But there's some instances where that is really important, like in this case of a uterus that had a mild septum right there that you can see. Depending on the location of that placenta, you can tell that patient, oh, you're okay, you're fine, that pregnancy will continue on. But there are other instances instead where the placenta, where the embryo is implanted right where the, for instance, in this case, this was what we used to call an angular pregnancy. But if you have the embryo that is implanted where there is the horn or the interstitial side of the uterus, and then that pregnancy will fail. And so you would follow that a little more closely. And indeed, when we did the fetoscopy here, we found that the placenta was actually implanted right where it shouldn't be, right next to the ostium of that tube, of that left tube. So other instances when it is important is, for instance, when we have twin pregnancies. And in this case, I don't know how, but I possibly performed that embryo transfer a little lower. And so I deposited the embryos, or they migrated possibly, but they went lower in the cavity. So you can see the internal os is here, and then you have these two gestational sacs very close to it. So we're like, oh my gosh, this is going to be a placenta creta. We're going to lose the pregnancy, possibly jeopardize the mother's health. But then looking at where the embryos were implanted, so on the lateral walls, then we said, okay, as the uterus will grow during that pregnancy, then also those two placentas will be higher up, and so we will not have so many issues. So in these little or few instances, knowing where the placenta will be will help you tailor your follow-up for these pregnancies. When we have the C-section scar ectopic pregnancies, it's also again important to know where the placenta could be, right? Because I don't know here in Europe, but in the United States, the C-section scar, it's called an ectopic pregnancy, and so we normally always intervene. But then some patients that adamantly will just say, I don't want to have this pregnancy interrupted. And so sometimes knowing where the placenta will be will help us tailor that conversation with the patient, convince her one way or the other. Another instance where this was helpful, unfortunately not for the outcome of this pregnancy, but for us to understand what happened, was this case that we actually published with one of my residents. And in this case, after the embryo transfer, you can clearly see that at 6 weeks, the placenta would form right at the fundus of the uterus. And then at 7 weeks, we saw that the pregnancy was there, but there was a large subchorionic hematoma that was SCH stands for. And we couldn't understand why she had this very large subchorionic hematoma. And then at 13 weeks, when she went on to her OB doctor and they did this ultrasound, they found that there was a velamentous insertion of the cord. And the patient then went on to miscarry at approximately 15 weeks gestation. And at that time, again, we could tell, so the placenta should have been fundal, like it was found also at 13 weeks, but then the insertion of the cord was completely different. So in summary, for this placenta location, it can be assessed as early as the yolk sac is visible, so around 4 to 5 weeks gestation. Knowing the placental position early in pregnancy could be of help in predicting the outcome of ectopic pregnancies, like cervical or corneal pregnancies, and as we said, also for abnormal placentation. So we're jumping now to the prediction of early pregnancy loss, and we're putting everything together, right? We want to evaluate all these parameters that we saw before and see whether we can in the end, predict pregnancy loss. So we evaluated those 239 pregnancies, and we followed them up, as I was telling you before, not just for the yolk sac and its appearance, but for all the other parameters. And among the red dots that you saw before, we also wanted to see what was the first parameter to become abnormal, so that we could possibly tailor our, again, our consultation for future pregnancies. And so in here you can see that yolk sac, and the colors are inverted. So the red color is actually the normal ones. Instead, the blue colors are the ones that miscarried. So here you can see that that the yolk sac was abnormal since the very beginning in those that miscarried. So at 5 weeks gestation, you could already tell whether a pregnancy would go to a good end or not. And then the gestational sac, yes, it's a great indicator of an impending loss. However, it only starts becoming significantly abnormal only later on in that pregnancy, so typically around 7 weeks. The same is for the embryo measurements. The crown rump length starts becoming abnormal at around this 7 weeks gestation. And the heart rate was a little all over the place, right? Whenever you have a decreased heart rate, it's not so indicative of an impending miscarriage, just because it's very close to the actual miscarriage that the heart rate does become abnormal. So, so not a great indicator. So the yolk sac is actually the very first one. So just keep that in mind and study that little organ better whenever you do your first trimester ultrasound. So in conclusion, the pregnancy structures can be identified from 4 weeks gestation. The ultrasound can distinguish normal from abnormal pregnancies as early as 5 weeks gestation. Placenta location can be diagnosed as well at 5 weeks gestation, and the cord insertion can be diagnosed at 7 to 8 weeks gestation, and once we know the placental position. So why do we have to know again? Because we want to perform targeted follow-up and very early counseling for our patients. And with that, I thank you so much for your attention. I hope I was not too long. Thank you so much.